if you hear the word diabetes, you probably immediately picture a lack of insulin.
Right, yeah.
Like you picture a dry gas tank, basically. I mean, the standard assumption most of us carry around is that it's this very clean mechanical problem where the body just stops producing what it needs.
Exactly. It's a very simple narrative.
Yeah, but what if you looked under the hood and found that the tank wasn't empty at all? What if it was actually overflowing?
Welcome to today's deep dive. I'm your host, and today we're getting into a stack of really fascinating sources covering the pathophysiology of type 2 diabetes.
And I'm thrilled to be here for this one. It's such a crucial topic.
Oh, it really is. Because our mission today is looking at the invisible cellular breakdown that happens decades, literally decades before a doctor ever flags your blood sugar. We're looking at what actually happens when your cells just decide to flat out ignore insulin.
Which is, it's a profound shift in perspective.
Yeah. Because for so long, the medical narrative was entirely focused on absence. Not enough. But the reality of the pathophysiology, the actual chaos happening inside the cells, is a story of overwhelming excess, not deficiency.
Right.
But to understand how our cells break down today, we actually have to look at how the scientific consensus broke down in the past.
Okay, let's unpack this. Because for most of the 20th century, the disease was treated as this single entity defined just by its endpoint, right? Sugar in the urine. Nobody really understood the mechanism.
No, not at all. And that massive blind spot, it stems from the 1920s.
Right, the discovery of insulin.
Exactly. You have Banting, Best, McLeod, and Collip. They extract insulin, they give it to a starving 14-year-old boy named Leonard Thompson, and it miraculously saves his life.
Which is incredible.
Oh, it was arguably one of the greatest medical breakthroughs of the 20th century, but, and this is a big but, that miracle created an incredibly stubborn paradigm.
Because Leonard had a specific type of diabetes.
Yes, he had what we now call type 1 diabetes, which is a genuine autoimmune destruction of the pancreas. So the discovery reinforced this dogma of, the patient is sick, you give them insulin, they get better, therefore all diabetes must be a deficiency disease. Full stop.
Wow. So they just applied that to everyone?
Pretty much, yeah.
But that logic starts falling apart in 1936, right? Harold Hemsworth publishes a paper in The Lancet that completely disrupts the narrative.
Yeah, Hemsworth is looking at how blood glucose drops after an insulin injection combined with a glucose load, and he identifies these insulin-insensitive patients.
Insulin-insensitive. So people whose blood sugar barely budges, even when you literally inject them with insulin.
Exactly. He's staring at this data and realizing that the dogma is just wrong. It's not a lack of the hormone in these patients. It's a failure of the body to actually use it.
He had essentially identified insulin resistance.
Right. 50 years before it became central to our modern understanding.
That's wild.
But the problem was nobody could truly prove it. They just didn't have the technology to measure the microscopic amounts of insulin that were naturally circulating in the human bloodstream.
Right, which means science had to wait, 20 years to catch up?
Yeah, about 20 years.
And that happens in the 1950s with Rosalind Sussman-Yaralow and Solomon Burson. They invent the radioimmunoassay.
Yes. The radioimmunoassay, or RIA, was a total game changer. It uses radioactive isotopes to tag and trace microscopic hormone levels in the blood.
So for the first time, they could actually see what the body was doing.
For the first time, researchers could see exactly how much native insulin a patient was producing. And when they tested Hemsworth's insulin-insensitive diabetics, the results sent shockwaves through the medical community.
Because they didn't just have normal levels of insulin.
Yeah.
They frequently had it in massive, higher than normal amounts.
Yeah.
The pancreas was just pumping it out frantically.
Exactly. They finally had molecular proof. Yaralow eventually won the Nobel Prize for this work in 1977, and it fundamentally fractured that Banting-era deficiency model.
It forced them to realize there were two entirely different beasts here.
Exactly. Type 1 is a genuine autoimmune destruction of the beta cells. But type 2 is driven by this cellular resistance, where the body is literally drowning in its own insulin, but can't use it.
It's like, I was thinking about this, it's like thinking a car won't start because it's completely out of gas. You keep trying to pour more in, but when you finally take a wrench and look under the hood, you realize the engine is actually completely flooded.
That is a perfect visualization.
Right. Adding more gas isn't fixing the underlying problem because the spark plugs are drowned.
Yeah, and yet it took decades for the clinical world to adapt to that reality. I mean, we used to categorize them as juvenile onset and adult onset, which is now actively wrong.
Cascades are getting type 2 now.
Yes. With the skyrocketing rates of pediatric obesity, we are seeing adolescents developing severe insulin resistance. The age of onset is meaningless now. The underlying cellular mechanism is the only thing that actually matters.
Okay, so let's zoom in on that mechanism. If the engine is flooded, if there is plenty of insulin floating around in a type 2 diabetic, why isn't the cell responding? Because based on the sources, we know the insulin docks on the outside of the cell perfectly fine, right?
Yes, the receptor itself isn't broken.
Okay.
The insulin molecule binds to the insulin receptor on the surface of your muscle or liver cells without any issue at all. But binding is just the first step. That docking is supposed to trigger a highly specific signaling cascade inside the cell.
Like a relay race.
Exactly. The receptor activates a substrate called IRS1. That substrate activates an enzyme called PI3 kinase. That activates a protein called ACT.
Which is the trigger that actually lets the sugar in.
Right. The ultimate goal of that entire relay race is to signal glucose transporter proteins, specifically GLUT4.
GLUT4, okay.
Yeah, these GLUT4 proteins are stored deep inside the cell. When the cascade reaches them, they move to the cell surface, embed themselves in the membrane, and open up like a gate.
Just allowing glucose to flood out of the bloodstream and into the cell to be burned for energy.
Exactly.
So, if the insulin binds perfectly on the outside, the message is getting dropped somewhere in that internal relay race.
Yeah.
The IRS1 to PI3 kinase connection is being blunted.
Yes, that's exactly where the breakdown happens.
It sounds like a faulty lock and key. Like the insulin is turning the key in the front door, but something has physically jammed the deadbolt on the inside, so the GLUT4 door just won't open.
It is a jammed deadbolt. And the central culprit jamming that machinery, what's really fascinating here is it's ectopic fat.
Ectopic fat.
Yes. This is lipid accumulating in places it simply does not belong. Normally, your fat should be safely partitioned away in subcutaneous adipose tissue, under the skin.
Right.
But in this state, fat starts getting stored as hepatic steatosis, which is inside the liver cells, and intramyocellular lipid, which is fat inside the muscle fibers.
And when fat gets misplaced inside those organs, it creates these toxic byproducts, right?
Mm-hmm.
Ceramides and diacylglycerols.
Yes, exactly. These lipid metabolites are the actual gunk in the lock. Ceramides and diacylglycerols accumulate inside the muscle and liver cells and physically interfere with that IRS1 signaling chain.
Yeah.
They activate rogue kinases that actually phosphorylate the IRS1 molecule at the wrong spots, effectively turning off its ability to talk to PI3 kinase.
So the signal just dies.
Yeah.
The GLUT4 doors stay shut, and the glucose backs up into the bloodstream.
In the muscle, yes. But in the liver, something even more chaotic happens. Your liver is basically a glucose factory. It produces sugar to keep your brain fueled when you aren't eating through a process called gluconeogenesis.
Right, it makes its own sugar.
Exactly. Now, normally, a spike in insulin after a meal tells the liver, hey, we have plenty of food, shut down production.
But because the liver's internal deadbolt is jammed by this ectopic fat, it never hears the insulin.
Precisely. It becomes completely deaf to the signal, so you have a devastating paradox.
It's like a broken thermostat. I mean, the house is already boiling hot, the blood is full of glucose from the meal you just ate, but the liver thinks it's freezing.
Right.
It acts like you are fasting and just keeps pumping out even more glucose into the blood. That is crazy.
And to make matters worse, this entire environment triggers a vicious inflammatory loop. When your subcutaneous fat tissue reaches its storage capacity, it becomes highly inflamed.
It just runs out of room.
Yeah, and it starts secreting these inflammatory cytokines like TNF-alpha and IL-6 into the bloodstream. These cytokines travel to the liver and muscle and further disrupt that insulin signaling cascade.
Just piling on.
Yeah. And at the same time, your fat tissue stops producing adiponectin, which is a protective hormone that normally helps sensitize your cells to insulin.
So you have a flooded engine, a broken thermostat, and this chronic low-grade inflammation just actively pouring glue into the deadbolt.
That sums it up perfectly.
But this cascade of failures, it doesn't just happen overnight.
Yeah.
How long is this lock jammed before a doctor actually spots a problem on a routine blood test?
That is where the longitudinal data tells a very sobering story. The National Institutes of Health runs a field station in Phoenix, Arizona, where researchers have been following the Pima Indian community for decades.
Oh, right, the Pima Indian studies.
Yes. This population has one of the highest recorded prevalence rates of type 2 diabetes in the world, and researchers like Clifton Bogardus and Eric Ravusin utilize something called the glucose clamp technique to study them.
Okay, the glucose clamp. How exactly does that work in practice? Because it sounds kind of intense.
It is intense. It's the gold standard for measuring insulin resistance. You literally clamp the patient's blood sugar at a specific baseline level by constantly infusing them with an IV of glucose.
Okay.
Then you infuse insulin and measure exactly how much insulin it takes to keep their blood sugar perfectly stable at that clamped level. If it takes a massive amount of insulin to hold the line, you know the patient is highly resistant.
Okay, so they are getting incredibly precise, real-time measurements of how deaf the cells are. And what did they actually find?
They found that measurable severe insulin resistance often precedes a clinical diabetes diagnosis by many years, sometimes decades.
Decades.
Yes. They proved that this resistance, combined with a struggling pancreatic response, was the absolute strongest predictor of future diabetes.
So your cells are ignoring insulin for years.
Yeah.
But your standard fasting blood sugar looks totally fine because your pancreas is just working overtime, pumping out more and more insulin to overcome the jam.
Exactly. It's compensating. But it can't compensate forever. And that brings us to the UK Prospective Diabetes Study, the UK-PDS, which ran from the late 70s into the 90s.
Right.
They tracked beta cell function, the actual factories in your pancreas making the insulin. They found that on the very day a patient is newly diagnosed with type 2 diabetes, their beta cell function has already declined by about 50% compared to a healthy person.
Wait.
Yeah.
Stop there.
Yeah.
If the UK-PDS shows a 50% loss of function right at the moment of diagnosis,
Yeah.
aren't we treating the start of this disease completely backward? It feels like we are arriving at the third act of a movie and calling it the opening scene. We've missed all the character development, the slow building tension, and we're just jumping in when the explosions start.
That is a highly accurate assessment. We are arriving incredibly late to the scene. Type 2 diabetes is a slow, silent burn. Your body compensates by pumping out massive amounts of insulin until the beta cells finally begin to exhaust themselves and die off.
Why do they die? Is it just exhaustion from working too hard, or is the environment actually killing them?
It's the environment. Once your blood sugar and blood lipid levels stay chronically elevated, those excess sugars and free fatty acids become directly toxic to the beta cells. We call it glucotoxicity and lipotoxicity.
Wow.
The chronic high glucose overstimulates the cells, causing severe oxidative stress and something called endoplasmic reticulum stress.
So the internal machinery of the pancreas cell is literally burning itself out.
Yes. The stress becomes so profound that the beta cells initiate apoptosis. They undergo programmed cell death. The toxic environment forces them to essentially self-destruct.
Okay, so if we are catching it in the third act, and the beta cells are actively dying off due to lipotoxicity, is this just a one-way street? Because for a long time, the clinical narrative was that diabetes is a permanent, progressive decline. You just sort of manage the fall. Can we rewind the tape?
We can, and that realization is one of the most hopeful shifts in modern metabolic research. British researcher Roy Taylor proposed what he calls the twin cycle hypothesis.
Okay, what is that?
It builds perfectly on our jammed deadbolt analogy. The first cycle is excess calories driving fat accumulation specifically into the liver. That liver fat causes the insulin resistance, so the liver pumps out too much glucose.
And the second cycle.
The liver eventually has to offload that excess fat, so it exports it via the bloodstream, and it ends up accumulating in the pancreas.
So it moves.
Exactly. That pancreatic fat physically impairs the beta cells, causing that lipotoxic burnout we just discussed. Taylor's theory was that if you could somehow drain that ectopic fat out of those specific organs, you could reverse both cycles.
Right, and here's where it gets really interesting. To test this, Taylor ran the direct trial. And the parameters of this trial are wild. They took primary care patients and put them on a liquid diet of roughly 825 to 853 calories a day for 3 to 5 months.
Yes, a very intense, very low-calorie dietary intervention.
But wait, 800 calories a day, that's practically starvation level. Is that even a realistic treatment model for the general public? Or was this just a biological party trick to prove a metabolic point?
It's a highly controlled proof of concept, yes, and it requires intense medical supervision. But the goal wasn't just general weight loss. It was a targeted strike to rapidly deplete the glycogen and fat stores in the liver.
Good.
And the results from 2017 were staggering. Roughly 46% of the participants achieved diabetes remission at 1 year, meaning their blood sugar dropped completely below the diabetic threshold without any medication at all.
Because they drain the fat from the liver and the pancreas. They unjam the deadbolt.
Exactly. And we see this mirrored in major bariatric surgery trials, like the STAMPEDE trial, where surgical weight loss produces identical rapid improvements in insulin sensitivity. But we have to be incredibly careful with our vocabulary here. We use the word remission, not cure.
Right, because the underlying susceptibility hasn't vanished. If the patient goes back to an energy surplus and the ectopic fat returns, the lock jams all over again.
Precisely. You are reversing the disease process by clearing out the specific hepatic and pancreatic fat. You are unflooding the engine. But if caloric excess returns, that fat will redeposit in those vulnerable organs, and the resistance and beta cell dysfunction will immediately return.
Okay, so if draining fat reverses the disease, it is incredibly easy for someone to assume this is just a disease of people who are visibly overweight. If you carry excess weight, you get diabetes. If you're skinny, you're safe. But the data reveals a massive, dangerous blind spot in that kind of thinking.
A blind spot that has caused immense harm. For decades, the medical establishment operated under the visual assumption that type 2 diabetes only affected overweight adults. But there's a well-documented phenomenon called 2FI, thin outside, fat inside.
Meaning you can have visceral and ectopic fat accumulating inside your liver and pancreas, destroying your insulin signaling while looking completely lean on the outside.
Yes, exactly.
Judging your diabetes risk by looking at a bathroom scale is like judging the structural integrity of a house by looking at its paint job. The exterior walls might look pristine, but the foundation could be completely eaten through by termites.
This raises an important question, right? Think about how medical biases have historically delayed care. This is particularly prevalent in South Asian populations, who frequently develop severe insulin resistance and type 2 diabetes at BMI levels that Western medical standards consider completely normal.
Wow.
The reliance on the scale and the assumption that subcutaneous fat is the only metric of metabolic health led to systematic underdiagnosis for entire populations.
And it feeds into this terrible societal stigma, too. The framing of type 2 diabetes as a purely lifestyle disease, like it's just a moral failure of willpower, diet, and exercise. It completely ignores genetics, socioeconomic access to high-quality food, and the heavy debate over evolutionary origins.
The origins debate is fascinating. In 1962, geneticist James Neal proposed the thrifty gene hypothesis. He argued that genes promoting highly efficient fat storage and insulin resistance were actually an evolutionary advantage during ancestral times of feast and famine.
So it kept our ancestors alive.
Right. But in our modern, westernized environment of constant caloric abundance, those same survival genes become lethal.
But that got heavily challenged in the 90s by David Barker and Nicholas Hales, who proposed the thrifty phenotype hypothesis. And this challenges everything.
It really does.
They argue that it isn't ancient genetics at all, but rather poor fetal nutrition while a baby is still in the womb. If a fetus doesn't get enough protein or energy during critical developmental windows, its organs actually adapt to expect a harsh, nutrient-poor world.
It's developmental programming. The fetus essentially downgrades its pancreatic beta cell mass and programs its peripheral tissues to be insulin resistant before it is even born.
Before it's even born.
Yes. It's a developmental mismatch that explains why low birth weight infants have a wildly elevated diabetes risk decades later in life.
So a baby's metabolism is permanently altered by the mother's nutritional environment. That removes the stigma entirely. A person's metabolic destiny can be shaped by forces completely outside their control before they take their first breath.
While neither the thrifty gene nor the thrifty phenotype hypothesis is universally accepted as the sole answer, they both demonstrate that the pathology is immensely complex.
Okay, so it's not just a weight issue on the outside. It's not just a sugar issue, and it might be programmed in the womb. It is a massive systemic collapse.
Right.
Where does that leave us today in the clinic, especially with all the noise surrounding these blockbuster weight loss drugs?
Well, to understand the modern clinical landscape, we have to recognize how much our view of the disease has expanded. We talked about the liver, muscle, and pancreas. In 1987, Ralph DeFronzo called that the triumvirate of defects.
Right.
But by 2009, after decades of utilizing the glucose clamp technique, he expanded this to what he called the ominous octet.
8 different organ systems failing simultaneously.
Yes. The liver, muscle, fat cells, pancreatic beta cells, pancreatic alpha cells, which secrete glucagon, the kidneys, the brain, and the gut. Type 2 diabetes doesn't exist in isolation. It is deeply connected to a massive web of metabolic dysfunction.
Which explains why it travels with so many other conditions,
Mm.
like metabolic syndrome, which Gerald Reaven originally called Syndrome X. It's basically insulin resistance manifesting everywhere at once. Central obesity, high blood pressure, skewed cholesterol.
Yes.
Then you have NAFD, the fatty liver disease, which shares the exact same root cause of ectopic fat. Even polycystic ovary syndrome, PCOS, is now understood to be heavily driven by this exact same systemic insulin resistance.
If we connect this to the bigger picture, recognizing this 8-organ system failure is incredibly empowering because it helps you reason about why specific interventions actually work. Take the GLP-1 receptor agonist drugs that are dominating the cultural conversation right now. Semaglutide, known commercially as Ozempic and Wegovy.
Right, everyone talks about them as if they are just magic Hollywood weight loss injections that fell out of the sky.
Yeah.
But they're operating directly on this pathophysiology, aren't they?
Absolutely. They were initially developed to mimic a gut hormone that enhances the body's own insulin secretion and suppresses appetite signals in the brain. But they have produced weight loss so substantial that it drastically improves insulin sensitivity in ways that directly echo the mechanisms we saw in the DIRECT trial.
So what does this all mean? They are essentially clearing the ectopic fat. They are draining the liver and the pancreas. The drugs are just a new, highly effective tool to leverage the exact cellular mechanisms that researchers like DeFranco and Taylor have been mapping out since the 70s.
Exactly. They're turning a decades-old pathophysiological insight that reversing ectopic fat reverses insulin resistance into a clinical strategy. Knowing the mechanism rather than just obsessing over an A1C number on a chart is what allows a patient and a clinician to make informed decisions.
Right.
Whether it's an intensive diet, bariatric surgery, or a GLP-1, you are fundamentally choosing a tool to unjam that cellular lock.
This has been such a journey. Let's rapidly synthesize the core takeaways for you. First, the old dogma is wrong. Type 2 diabetes is almost never not enough insulin at the beginning. It is usually a massive excess of insulin that the body's cells are simply ignoring due to a jammed internal signal.
Second, this is a silent, slow-burning process, and by the time you actually receive a clinical diagnosis, the toxic environment of high lipids and sugars has already forced 50% of your insulin-producing beta cells to die off.
Third, the mechanical driver connecting obesity to insulin resistance isn't your overall subcutaneous body weight. It is ectopic, fat-misplaced lipid actively interfering with the liver and muscle.
And fourth, because of that mechanism, the disease can often be put into remission through targeted, sustained weight loss that drains that fat.
And finally, lean people are absolutely at risk. The TOFI phenomenon proves that visceral hidden organ fat, not the reflection in the mirror or the number on your bathroom scale, is what actually determines your metabolic danger.
As we wrap up, I want to leave you with a thought that builds on what we discussed regarding the thrifty phenotype.
Yeah.
If poor fetal nutrition really does program a baby's metabolism for insulin resistance before they take their first breath, are we currently witnessing a massive generational snowball effect?
Oh, wow.
Right. And if so, treating the individual adult today with GLP-1s or intense diets might just be a Band-Aid. How might we need to completely redesign maternal and global nutritional health to stop the cycle before it even starts?
It's a massive question, but it's exactly what we need to be asking. Because as we've learned today, if you keep pouring gas into a flooded engine without ever looking under the hood to see why the lock is jammed, you're never going to get the car to start. Thanks for taking this deep dive with us. We'll catch you next time.